so many of those people that we have in the ICU right now, they're not even on isolation for COVID anymore. After 21 days at most of the metro hospitals, again, I can only speak for Integris, but for most of the metro hospitals, after 21 days, we take those people off of isolation, but they're still on a ventilator and their lungs are still rock hard. And so those ICU beds are not empty. They're just not acute COVIDs anymore. They're what we call COVID convalescing. And those people, I rounded on 5 people today who were admitted in August. So I mean, it's still, even though the numbers have gone down a little bit, although we had a pretty good weekend, 4,000, I think. Is that what it was?
Yeah,
a pretty good weekend. Pretty productive. So it's we'd like to go down a little bit faster, and then I know that we had a bunch of admits over the weekend, over the weekend, and especially in the last couple of days. I was talking with one of our lead hospitalists today, so it's going to be a little bit of ebb and flow, and hopefully we'll get those ICU beds freed up and get those nurses back working, and get everybody kind of in the chute. But it's going to continue to be a struggle.
Yeah, I think people need to understand that, hospitalizations, that COVID patients are longer than the average patient used to be. And the ICU beds, when occupied, stay occupied. I'm here in beautiful downtown Lawton, thriving metropolis, but there's no beds down here. I asked. And so it's not just in Oklahoma City, it's throughout the state. It's an issue. So, we can talk about all we want, that the numbers are going down, the deaths lag, but we still have more than 10,000 deaths. We still have people in the ICU, and we still have disease. So we want to certainly encourage everybody to get vaccinated. I'd like to move into sort of what's happened this week. This has been really a very exciting week. A lot of requests to the FDA for different authorizations. We learned that Pfizer has sent in their request for children 5 to 11. I think that's going to be huge. They studied about 2,200 children, which bothers me that it wasn't more than that. But they're talking about a third of the adult dose given twice. Dwight, what do you think about this? Is it going to make a big difference?
I think we definitely want it as quickly as possible. I feel like that. Yeah, you'd like to have more numbers than that. But the data that we have at this point, with the third of the dose, the 10 microgram as opposed to the 30 microgram dose with the Pfizer vaccine, the data looks pretty good to me. Now, is there going to be problems after we get going? Who knows? We're just going to have to watch closely. But I think there's more pros than cons to get this thing going and try to get as many people vaccinated, including the children. Even though we're over 6 million kids now, cases, the number of cases are going up more in children than adults, or the percentages are going up. Hospitals rates have gone up some. It's not just been just drastic, but it's up. And mortality is not, thank goodness, is not just going out the roof either. I saw 520, but that's probably not accurate. I don't know as far as number of nationwide deaths from it, from children. So I think it's time. I think we need to get it going. I think the kids will do well, as I've said before. I think they're going to parallel what we've seen in the adults. That's my feeling on them.
One of the big things that I read was that because of the small numbers, the study might not be large enough to see some of the rare side effects.
That's true.
You think that's going to cause some hesitancy, John, in parents with younger kids?
I think any of the information that's flowing out is going to be processed differently by different subsets of the community. Unfortunately, I think if somebody really focuses on that in the media, then you're going to get people who make that an issue for them and their families. To me, absence of data is not, absence of evidence is not evidence of absence. It does. You can't really read into that missing data enough to really advise people, which is a problem. Hopefully,
Well,
they're accruing more patients to help plug the gaps. There's no reason to believe that there's going to be a whole host of complications that are uncovered by that extra data. I mean, there's I don't understand the physiology that would say, oh yeah, this is the age group that's going to be more at risk, for side effects. But
even in the
possibly
adult studies,
myocarditis or
though,
something.
even in the adult studies, I mean, all that stuff came out post release, right? I mean, it's not like we saw in the original studies that there was a bunch of myocarditis, and there was not a bunch of myocarditis. There are occasional cases therein, and still, 10 per million, maybe 4 per million in women, 17 per million in men age 15 to 30. I mean, still exceedingly rare. So I think. I'm not sure I can think of a medicine that's ever been released that didn't find some post-marketing phenomena occasionally, and sometimes drugs get pulled. I don't think that this one will. I think kids are, as we all know, much more resilient than adults. I think they, the data has shown us throughout time that they tolerate things much better than we do. So, but you're right. 2,200 is not a great number. I can see where that was a difficult study to recruit to in that environment. They were trying to recruit into it. I know a few kids who went and did it, but it was tough to recruit into that. And so,
I think it comes
that being
down.
said, you can still extrapolate some of the stuff from the adolescent data and things like that, can't you? Right? I mean,
I think it comes down to the benefit risk. I would much rather go with the risk of the vaccine versus the risk of the disease. And we would love to have more data. We always would, but even in this situation, that I think that we go with it, watch it close, and I'm reasonably confident that this is going to go well. I really think we will.
There's an opportunity here to change up the paradigm a little bit. We know if it's approved, there will be folks who are confident in the data as presented and will vaccinate their children. Let's start accruing those folks, and let's promise, an N of 8,000 is enough for us to get a statistically relevant sample, which will accrue very quickly by opening this up. But let's change up the paradigm. Let's be honest with the parents who are reluctant to say better data is on the way. Here's the number, and here's when we think our best guesstimate is when we'll have that data crunched. Wouldn't that be a refreshing way to sort of let people see the radar ahead and make determinations? Some people won't need that extra confidence. They're going to be really concerned about, and as Dwight said, they're going to do their risk-benefit analysis and come down right now, right away, get the vaccine. Well, those are folks who can help us understand for the less confident, let's accrue 10,000, let's accrue 50,000, whatever the statistical rigor is. And let's be honest, like the data you get at 10,000 won't be as good as the data you get at 50,000. But why don't we go down the journey of telling folks what this could look like? Let's trust the public to make their own assessment at 2,000, 10,000, 50,000, and then publish it and tell people where to go and find it when it's published. And when some experts have massaged the data, it's going to come out raw. It's going to need some, translation for the public, but that doesn't take forever. But anyway, I just think this is a great opportunity once again to change up and trust the public to be smart about their families and their decisions and their confidence. You're going to find a lot of people very confident in taking the vaccine with the present data.
I think that's a great idea.
Trust them.
I think it's great.
Yeah, I think trying to be transparent is something that medicine, and we've talked about it on this show, medicine's had difficulty with for as long as I can remember. And it's certainly been difficult during the pandemic. So communication, being transparent, I think is vitally important when it comes to the children. We need to let parents know what's going on. Let them make a decision. Don't villainize them.
Keep them informed. Yes.
one of the things that, and David just brought this up, the small number in the under 30 with cardiovascular, cardiac disease, I'll say, not really vascular, but cardiac disease. If you look at the countries of Sweden, Finland, they've stopped giving Moderna to the under 30. And, the numbers are small. I mean, the number of under 30 who got cardiac side effects was very, very small, yet they've stopped it. Is that something we're going to see elsewhere? And are people going to use that in the United States to say, whoa, not me, you're not vaccinating me or my kids?
Well, that's what the FDA advisory committee essentially said, though, isn't it, Larry? I mean, you had 8-6 vote to, or 9-6, whatever it was, to not approve the boosters in 18 to 49 for that very small risk, which was close to about the risk of hospitalization in that same cohort. If you take a vaccinated cohort of 18 to 49-year-olds who aren't at high risk of contracting it, or aren't at the highest risk, like, someone like me, not that I'm 49, but that the risk of the very small risk of myocarditis in repeat doses might have been. And again, this is the same thing John was just talking about, continued accumulation of data after the study is over. You can't accumulate data on the same rigorous level that you can in a double-blind randomized controlled trial. But it doesn't mean you can't get useful data. And we have got a ton of useful data out of this in terms of, seeing where people are after vaccination, what antibody levels are. Those aren't the same rigorous protocols that were derived during the original studies, but there's still useful stuff there. And we need to continue to collect that. From here, the Israeli data has informed a lot of U.S. policy because they have done a pretty rigorous job of post-marketing data collection, much more rigorous than the United States has. The VAERS is not a great system for doing this kind of stuff. But we'll just continue to see that kind of data collection and sort of try and draw conclusions the best we can off of it. I think, though, the vast majority of people, particularly people with risk factors, now that's an 18 to 49-year-old perfectly healthy person. That's maybe 40 or 50% of Oklahomans, so there's a lot of not healthy 45-year-olds. If you're diabetic, if you're overweight, I mean, you still need to go get it. So I think that you have to be honest with yourself about what your risk factors are. Make the best. We've never said anything but making the best decision here, but the best decision by and far for the vast majority of people in the state of Oklahoma, in the country of the United States, and around the world is to get vaccinated.
Well, you guys probably covered it last week. I'm sorry I missed the record-breaking session that Scott was mentioning. But, to me, part of these risk-benefit equations, they're moving targets. When you get molnupiravir, or I'm probably mispronouncing that, but the new Merck drug in the mix, hopefully it'll get an EAP or a EUA or some access early, again on the basis of let people make the decision. I know if I had a loved one who was ill right now, I'd be clamoring to, hey, when's the pill available? When's the pill available? But that changes the risk benefit calculations. When you put a big new chess piece on the board, all the other bets on outcomes are recalculated. I wish the CDC would hook up with the folks in Las Vegas and we could, start factoring in, some of these changing, adapting risks that people really need the education. It does fundamentally, once that's approved, if it's as good as touted, that changes the calculations. It has to. But again, we're not even having a risk-based discussion, which is frustrating because, again, it doesn't empower the public to sort of assess, where are we going with this? what is the best decision for my loved one if this becomes available, hopefully within a matter of a few weeks here at the latest. But we haven't laid the groundwork because we haven't done the transparency before. We haven't kind of gotten practiced. We could have, but we haven't on this kind of, well, where does that risk of myocarditis fall compared to my risk of playing golf in the rain and getting hit by a lightning bolt, or driving my car, or, eating yogurt that's unpasteurized, or whatever it is. Again, we might as well start now. Now's as good a time as any to start developing that sophisticated model to inform a public that needs it, a public that's clamoring for it. I mean, you see this twisting and turning out there on the internet, and it's a cry for help. The public wants the kind of solidity to the information, and all they're getting is sound bites and superficial. And maybe this moment, wouldn't it be great, this moment where we're starting to see new therapies come online, for younger folks, as well as new antivirals, open it up. How many people are being managed towards getting vaccination at this point that we can't trust them with the information about an antiviral, and what it might do or might not, because they might not get vaccinated? That's a loser's game at this point. There are very few fence sitters left in this game that you can manipulate with controlling how much transparency you have and how much information, and really articulate voices of risk-benefit discussions. Open that up now. There's no game to be played with. To me, what are you hoping for? 2% more vaccinations?
What kind
go
of
ahead. Go ahead,
quickly,
Dwight.
what kind of trial is done on the oral medicine as compared to the vaccine? Is it a less stringent trial, or
no? It's an RCT. We went over it last week. Was there maybe 350 total participants? I feel like about 180 in each arm, something like that.
It was somewhere in that. It was in the hundreds.
Okay.
4 days of therapy, 5 days. I can't remember.
It's 5 days of therapy, 4 pills a day, 2 pills twice a day.
4 pills twice. Yeah, 20 pill
40
course.
pills.
But it was a double-blind, placebo-controlled deal that showed a 50% improvement. But yeah, it's funny to me, and we've talked about this with monoclonal antibodies, that folks are ready to decry the vaccine is not well tested enough when it's got over 6 billion doses now, or it's under an EUA, or it's not FDA approved, but happy to run to these other ones that don't have as much data behind them. The monoclonal antibodies obviously have a lot more because of post-marketing, because of release data that have shown tremendous benefit. But the barrier is, are you in a place that's giving it? If it's a 3-hour thing, there's only X amount of drug. The pill obviously is much, much more appealing. But people are trading one EUA for another, in my opinion.
But how many trials during the COVID last 20 plus months have we had stopped because one arm is so demonstrably better than the other arm, the untreated arm and the treated arm? I can't think of many that have come to that sort of rapid. The reason we don't have more accruals is they stopped accruing patients.
You're right. You're right.
Good point.
Absolutely.
Good point.
And if you have read, there's 2 more antiviral pills that are to come out in the next month or 2, one from Roche and one from Pfizer. So the waters are going to get even more muddied. And John's right. We've got to start clearing the air, giving accurate information that people know that they're looking at apples or they're looking at oranges, and being able to make informed decision. We try to do it on this show, but that's not the answer. The answer has got to come really from our federal government. It has to start there, where they give complete information so that people can look at it. One of the things that I read that I was not aware of, you all may be, but the molnupiravir, or however you want to say it, David, because I don't know, but can't be given to pregnant women because it could cause risk of birth defects because of the way it breaks the genetic chain. They're afraid that it'll do that in the embryo. And so it's not going to be able to be given to pregnant women. I wasn't aware of that. I haven't seen that out being publicized. And I know there are people who either think of getting pregnant or who are pregnant who are going, I can take the pill. I don't have to get a vaccine. But the vaccine is safe for pregnant women.
Mm-hmm.
The pill gives you a 50% reduction. The vaccine is 90+%. We need to have all that information in front of them.
We need it out there. Yeah.
You know, this is only half joking. What if we did open it up to Las Vegas bookies? They would drive into that data really hard to, to get the consumer better into this game. I mean, it's kind of, I'm joking, but it's that kind of desire for good information that we seem to not have a driver that can punch through the kind of sound bites and the superficial knowledge and the partial knowledge and the, like you're saying, Larry, the range of exceptions and the American public is capable in, you can't dump it all at once. And increasingly we've left a lot of this learning just to pile up on top of itself unresolved, which makes it very hard to sort out. But the public can understand things like teratogenic birth defects and, give them time. You can't dump it on them, but take us on that journey. Open it up, it's just so frustrating, but I would joke again that, maybe we need to put some of the odds makers, that's muscle right there. You want to figure out what's going on in the NFL? We got some experts for you, and they'll drill for some statistics, and they'll get you some, you can go to all kinds of fan sites and learn a heck of a lot about next Sunday's games. What if we have that going in the medical risk world of, how we should best treat people or who's going to be the best survivors out of these range of options? I bet we'd have a lot more clarity in a hurry.
And we talk about the waters getting muddied. I'm sure you all saw AstraZeneca also requested from the FDA that an EUA for a new long-acting antibody. They don't even have a name for it yet. AZD 7442. That's a great name. We can really educate the public on that. But another form of treatment for preventing disease. And as an outpatient, this is only going to get so confusing that doctors aren't going to know what to give, let alone the patients be able to understand it. So we really need to sit down. There's, we've just listed 5 different requests for emergency use authorizations for different drugs just in the first 30 minutes of this show. How are people supposed to keep up with this?
And into the lack of clarity comes the conspiracy theories and the bad, it's not that it's neutral. It's not leaving people kind of in the dark and without the tools to process these things as neutral. It's negative, because into that vacuum flow all kinds of weird ideas and people with political agendas or social agendas or whatever they have. It's not neutral. You're causing a harm by leaving that door open to misinformation. And we've seen it time and time again through this entire journey.
Well, and the public media, the newspapers and TV, they give such a superficial report on all this that people just don't understand. They think each one of these treatments are all equal, use the same, whatever. So, David, do you have any comment on this new long-acting antibody?
No, I mean, I kind of just saw a blurb about it. I haven't really dove into it at all. I think, as with any sort of groundbreaking therapy, and I mean, we can go down the list of any number of different groundbreaking therapies over time, fluoroquinolone therapy, all the different rheumatologic agents, all kinds of different things. When you find something that works, you get a lot of people coming into that space, right? And there's a lot of kind of Me Too type of movement that they're trying to get into that space also and come up with some different drugs that might. And I'm not saying we don't need them. I heard today that we actually do have a pretty good supply of monoclonal antibody in the state, and that we have lots of places that can give it. Probably not quite as many as we need, but nonetheless, with dwindling numbers, obviously there's a supply and demand metric there. I think that all of these things have to be looked at honestly. They have to be looked at, and that's where the FDA advisory committee is so important. I know they took a lot of flack for not advocating for boosters in the Pfizer 18 to 49-year-old group. But isn't that what you want? You want somebody looking at it first. I mean, like you said, John, we got to give people the information, but the people who understand the information the best in the world have to be the first ones to be able to start distilling that. The first distillation is probably the most important one, and then after that, it keeps going through different filters. But so you want to make sure that these drugs are up to snuff, and you know, you saw recently with the Alzheimer's drug, you know, where a lot of folks were pretty upset with the way that thing went. So it requires honesty on a lot of different levels. Yeah. We just need to keep looking at all of them. There's still lots of opportunities here. I mean, we got to remember in the 80s, and I'm thinking a lot of our audience will remember the 80s, the excitement when AZT came out in HIV, and AZT is nowhere near on our treatment paradigms anymore. The iterations of the newer drugs that came through, new scientific breakthroughs, and now, you know, we're down into totally different treatment protocols because of the science that kind of cut off on the science. So maybe this longer acting monoclonal antibody will be better. One of the more interesting conversations right now going on in science that I've seen is, why do we say 90 days until somebody can get a vaccine after antibody? Do the antibodies really hang out that long in your system? You know, that kind of. So there's constantly scientific questions that have to be asked and answered, addressed honestly, and then redistilled and regurgitated to the people that are the end users honestly and appreciably.
You know, the other, I love where you're going with that. And I think the other thing we need to realize is that people are asking questions that aren't being addressed very well. Not only are there certain drugs that are boiling up and they focus our attention because there are commercial elements to it, there are regulatory elements, there are certainly political elements, unfortunately. But just today, and I heard a conversation with two of our employees talking about they both had COVID at the same time, roughly. They'd had roughly the same symptoms, but we've started testing again, and thankfully they walk the walk and they're blood donors, and they came in and they have had a test in October where they got their results back, and they're like, one of them has the antibodies detectable and one of them doesn't. So they're sitting there trying to figure out why one of them is detectable and one of them isn't. And that's probably an idiosyncratic discussion of antibody levels and what they mean, but we're not. That's a question that is out there right now that we haven't educated people enough for them to be able to answer that. But it's not going to appear because there's no manufacturer right now. Maybe down the road, if there's a test and it drives boosters or something, then we'll start talking about the immunology, of antibody levels post exposure. But it's sad. We haven't armed these people with an absolutely natural question that we all know from our immunology courses is going to be, neither one, needs to worry about, where their antibodies are at this point in all likelihood. But we need to do more research, and we need to tell them we're going to try and sort this out, but it will probably take us years to get you a really, really firm answer on what antibody titers might mean for your boosters or but we're not even signaling that we're on that journey of investigation, and we are going to support your questions. It's also unanswered stuff that's, I guess, is what I'm saying. For as many questions as we bring up, there's probably twofold out there that people have that aren't getting any oxygen.
Well, can't you see, for example, when you get an immunization, there are people, myself included, with hepatitis A vaccine. I took that thing, I think 3 different courses, never mounted an antibody response. I don't know if I got protection or not. I've never got the disease. But can't that happen with vaccines too, that you just simply don't, and is it akin to the cases where they have the disease?
It's all immunogenic, right? I mean, we know 5% of people who take the hepatitis B series are non-responders. Right. And we repeat the hepatitis B series, and they don't respond again, and then they're labeled non-responders. So we've had years to collect that data.
Yeah.
But immunogenetics, to me, you're seeing. I mean, I've always been very, very interested in the field. It's a very nerdy field, really, really smart people in it, and to me, it's the crux of this whole COVID thing. Why does this guy who's diabetic and overweight go into the hospital with life-threatening COVID, and this other guy who's diabetic and overweight has the sniffles for 2 days and it's fine? I mean, the immunogenetics has so much to do with all of this stuff, John. I mean, and I think that those are going to. I think there's going to be a ton of money going into it from now on, and there has been for a while with all the new monoclonal antibodies, and I'm not talking about COVID monoclonal antibodies, but all the monoclonal, oncology, rheumatology, GI, dermatology. I mean, where all of these monoclonals are, that's always been a huge part of the immunogenetics. And HIV, we've been looking at it for a long time.
John, hold on just a minute, because I was going to bring actually this whole topic up. There is a psychiatrist, a physician, MD, at the University of California, Irvine, which is where I came from, who is actually suing over the fact that he had COVID, claims he has natural immunity, and therefore doesn't need to get the vaccine, which the university has mandated. And the judge basically ruled against this psychiatrist. The CDC,
he's the head of the bioethics committee there, if I'm not mistaken, isn't he, Larry? I think he's the head of the whole, which really makes it fascinating because
it's a fascinating story.
Involved quite a bit in the vaccine talks in the first place.
But what I was going to say is the CDC came out with a statement that antibody tests are worthless to determine immunity, and another expert quoted what happened in Brazil, where the Gamma variant went nuts, even though the majority of people were supposed to have antibodies to COVID. Yet they didn't have antibodies because of another variant that we aren't really seeing in this country to any great degree. And now we've politicized it. And this is where John's going to come in, because we've politicized it. The GOP Doctors Caucus in the U.S. Congress has urged people to get antibody tests rather than getting vaccinated. And
there's no
we don't have the wait a minute. The Kentucky legislature has granted equal immunity to those with positive antibody tests. They didn't say which one, whether it's to the spike or natural, but positive antibody test or vaccination. John, what do you think of all that?
Well, I don't think anybody should go to Congress and get treated by the Republican caucus of doctors or the Democratic.
Isn't Rand Paul a Kentucky doctor?
Well,
and what are his office hours?
He's obviously part of the GOP Doctors Caucus, and he's from Kentucky.
No doubt he is.
But I love the fact David was bringing up something that we're 20 months in, and immunogenetics is a huge part of this, as he rightfully points out. The fact that you've got in America 350 million people, that it isn't one size fits all, and our inability to do a soundbite that says there's gray. No soundbite ever loved the color gray. Because it requires another soundbite or three. It's sad that we don't have that level of sophistication as we enter this controversy about boosters and antibody titers, and we haven't laid any of the groundwork. We haven't dived deep previously, and now we're struggling because the sophistication that we know underlies a lot of the therapy, a lot of the monitoring, the public. They're at sea on this, and we as physicians, I don't think, have buffed our elevator speeches and have realized what language works to communicate these sophisticated concepts, because we haven't been given the practice time of talking about it around actual debate in the medical literature or in the public health literature or anything else in any substantive way. So we're kind of hoist by our own petard in a way. I think as physicians, we should be talking this language amongst ourselves and trying to spread it with a little bit more sophistication rather than reacting to the political or the commercial or whatever. I saw today in the Wall Street Journal, it really depressed me that they would cover this, but they were doing a backstory on the whistleblower who apparently had held up molnupiravir or whatever it's called, molnupiravir. And it was a political thing. It was like, why are you taking us down this journey? We barely learned the name of this drug, and somebody's already trying to put a political spin, which will suck up all the educational oxygen that we might have had about antiretrovirals and teratogenic, birth defect causing, nuances. Nobody's going to want that. They're going to want the anger and the emotion of somebody done somebody wrong, and there's no way of going back 12 months and knowing what this guy's motives were, or you can impute stuff, but you'll never know. Why go down that track just to generate anger or emotion or sales or whatever it is? And it's counterproductive. It denies us the chance to talk about the elements of this new treatment that we need to be coming to grips with. Who gets it? When do they get it? How, when will it be available? What are the mechanisms that the physicians need to know about that accessibility? The political framework that sabotages us from understanding the medical aspects. We've been hijacked. Science has been hijacked and weaponized and politicized, and it goes down to the daily paper. That's the level at which the public is, or the news report on CNN. That's the level at which they're seeing, or not seeing in this case, the consequences. Faster
than that, John. It's the tweet, and science doesn't move that fast. Heck, the news the daily paper doesn't move that fast. I mean, it is tough to continue to parry all the attacks when they come so quickly and so. The sound, like 140 characters, is brilliant, right? I mean, it gets everything you need out there. 280, whatever they allow now, and we haven't been able to get on top of it. That is a powerful force for giving out good information, but it is equally powerful at giving out bad information, and that's been our problem the entire time. But like you said, for some reason, someone decides that they just have to go and go with this story. I mean, that's on a lot of different people. If the media is doing it, shame on them. If it's Joe Schmo heard this at the lunchroom, shame on him. I mean, it's whoever's doing it. It's just doing things for shock value. It's all about shock value now. Everybody wants to be an influencer. Everybody wants to be talked about without really having any sort of gravitas to what they're saying all the time. Now, maybe they believe it, maybe they don't. I don't know, but I think a lot of times people just say stuff, did you hear kind of stuff, just to kind of get clicks.
Isn't it similar to what the whistleblower for Facebook said, that they put things out that get a rise in people because that creates more involvement. They stay involved. Well, the same thing people are doing. They throw it out there to get people involved, to get people agitated, and they react that way, and you become the center, the nidus of information at that point. So you have your 5 minutes of fame.
Knee-jerk response type thing.
I had a friend who really opened my eyes to a terrible perspective on this. We get the news we want. The fact that that I'm saying that I wish I had objective data. I wish I had transparency. I wish I had good risk benefit analysis. Apparently, somehow, the four of us seem to want it, and maybe a lot of the listeners, but we haven't figured out a way to signal to the media markets that there's any oxygen where we are. And they're going to continue to go to where the easy pickings are, because the people who want a more sophisticated answer haven't figured out how to signal the folks who can make a commercial go of that kind of depth. They don't see any hope there. So shame on us, because we somehow haven't empowered folks who I believe want to tell the story. I believe there are a lot of really great journalists who would like a deep dive, but somehow we haven't given them the critical mass, or I guess we haven't reformed the critical mass, reestablished the critical mass that the electronic media has blown up, right? So everybody's ducking for cover as the shrapnel from, the Facebooks and the tweets, and what that's done to disrupt the media environment. We haven't figured out how to reconfigure so that decent content serves the 5% that want the intellectual journey. They want the 5% in this market is huge. So why is everybody going after the same emotional bait and the same political bait that everybody's chasing that? I would say there's probably enough oxygen for folks to come up with a model that is objective, scientifically objective in this crisis in particular. Thankfully, Scott lets us come on because apparently there's some viewers who value what we're doing, and we're doing it kind of as the volunteer corps over here, with more media muscle and savvy. Imagine, not that Scott's not got a plenty of savvy to make up for the rest of us here, but imagine what you could do, if you were really intentional about supersizing what we do. Not with us necessarily, but with the expertise that would say, here's an ongoing, dedicated, not a volunteer kind of capacity to explain this. This crisis has a lot of energy to it. There are a lot of people searching right now, and there doesn't seem to be a go-to.
I agree with you.
Let's invent that. Not us, but the people who want the answers need to figure out how to signal to the people who can provide it that it's worthwhile chasing that. It's not all tweets. That space is filled and filled over again and filled again, and it produces a lower and lower common denominator of substance. All emotion, all the time, all near news, not real news, all preliminary spin. Anyway, sorry, soapbox.
Well, and John, I would only add that I would think that volunteer physicians like us need to be the ones doing it, because so many people think doctors only say things because they get paid to say them. They can't argue that with what we're doing. So, Scott, I know we're running short on time. I wanted to bring up the flu vaccine. John had sent out an interesting article, sort of collateral damage to what's happened with COVID. But do we have questions that we need to answer before we leave tonight?
Yeah, and we've got a few extra minutes here. By the way, Dr. Armitage, which is basically, that's a pretty good rant. I've been making notes, by the way. So,
notes for my counselor?
Right, exactly. Notes for the investigation.
Watch the news tomorrow.
I think the psychologists say that if you have a problem first, you have to admit it.
Yeah.
So, one of the things in all the years that I've worked with medicine, it's pretty hard for doctors to believe they have a problem when it comes to communications. And I'll watch, and sometimes I'll get messages from my friends like Dr. Bookman, and we'll be watching different groups, and I'll go, man, they are so bad. And, we'll laugh and have some fun. We go, but the problem is they think they're doing good. And that's the problem. I mean, and we see some of these things that have been happening over the last 18 months, and we go, what color is the sun in the world for these people are, right? The whole big lie and all this stuff. And you see some of these medicine, insurance, doctor groups, and they're doing a good job. And you go, no, you're not, dude. I mean, you're plugged into a matrix that is not working well. And so what you've been saying, Dr. Armitage, Dr. Chansong, Dr. Sublich, you said it too, no, Dr. Bookman knows this as well, is that whenever that you don't communicate to the level of the folks that are interested in that, especially in that middle. By the way, when you start looking at some of the polling that's being done in Oklahoma right now, there are a lot of people unhappy with the situation we're in terms of how COVID's being handled. And that has nothing to do with party, but the Republicans think it's being handled better than Democrats. But if you look at the last couple of months, I've seen 2 polls this week, both of which show that confidence in leadership is down about 20 points. That's a lot of points to shave off of you're doing okay. On a couple of the questions, Charla, I think that Katie Mitchell answered this, but Charla said, is Moderna going to recommend boosters at all? KD, who's my cousin, Kelly Mitchell, at RN. She said, my daughter's in the trials. They're giving her a booster tomorrow. So
Yeah, I heard. I know a lot of people that were in that trial got offered a second round of trial money to come in and do the boosters. And I believe, if I'm not mistaken, Moderna and Johnson & Johnson are both going with the FDA advisory at the end of the week, right? Isn't that the 15th and 16th maybe, or something like that?
Correct.
Coming up.
That's
So I
correct.
think that that's going to be a big deal. Moderna, they're recommending right now. It looks like they're going to recommend a 50 microgram, which is a half dose. But again, it's worth repeating that Moderna does look like it has a little bit better activity against the Delta variant in particular, and has stood up a bit better than the Pfizer, and the Johnson & Johnson, although they are all excellent. So stay tuned. That should be news this weekend.
Well, let me add to that too. This is, I think, very important information. They've also submitted for crossover to see if you got Pfizer, that you could get Moderna, you could get Pfizer. I don't know if J&J is part of that, but so that's an important piece that we've been asked about, and we don't have an answer.
I think Johnson Johnson may be a part of that.
It may be.
I may be wrong on
sure.
that. I know you definitely the Pfizer Moderna, crossover, but I think Johnson & Johnson maybe too, and then Novavax is on the book here pretty quick too. I think we're coming up for their EUA, aren't they?
It's supposed to be another month or two.
Is it?
I don't think it's going to be this one. So, but yeah, we should have answers October 26th when the CDC. That's after it goes to the FDA and the advisory, and
I think
CDC.
And I think right around that October 26th date is the day that Moderna is taking their adolescent data too.
Yeah, I was going to bring that up. They put in for an EUA 12 to 17 group.
Yeah. I have two more things, Dr. Bookman. Number one, so I may have mentioned earlier that, or maybe I did a tweet. So tonight we're on YouTube for the first time. So we're live every week on Twitter. We're live on Facebook, and now we're live on YouTube. And we're on the News 9 YouTube channel. So I was scrolling through the News 9 YouTube channel, which hasn't been used a lot, and they've really started using our YouTube channel a lot. There was a October of '79 story on there. Alex Cameron was 5 years old, I believe, when he was doing the story. It was a story.
Hello? Lost him.
Yeah.
1979, okay?
Yeah.
And this one doctor had, it was kind of like your beer, Dr. Bookman, about 4 times longer. And he was saying, there's just so much misinformation out there. But the interesting thing was, he said, but after we were explaining to the Amish that this was to keep their friends and neighbors from getting sick, they were like, okay, rack us up for it. And so they showed this in October of '79. They showed the Amish taking these drops for polio, an outbreak of polio in Pennsylvania. But it was interesting. So they were medicine was appealing in 1979 to the Amish in Pennsylvania by saying you could be helping your fellow man, and they were all down with it. Times have changed.
Used to work.
Yeah. Here's the last thing that I had on the agenda, and I tweeted this out earlier. We don't have much time on this one. USA Today did a really big article this weekend saying that the nursing shortage had less to do with vaccine mandates and things like that, but more about unsafe working conditions. That they felt like things were not well. They were concerned about the way they were being treated by patients' families. It's a big spread. The problem I have right now is it's behind the paywall, and I don't have a way of putting it to. I'll try to do something overnight. But nonetheless, it was not so much about vaccine mandates. It was just about burnout, and then they're just not hiring enough of us. It's unsafe. We're being disrespected. Huge story about what really is behind the nursing shortage.
I said from the beginning that I think that first wave, we had people taking extra shifts, everybody all hands on deck, and you haven't seen that. So, if you just look at the number of nurses versus the number of nursing shifts filled, I would say that ratio has changed from the first round of the epidemic. I think people are burnt out.
Yeah.
And I do think nurses. I read an interesting article about how much they were loved the first round and how much they have felt unloved. Not unloved, I guess.
Unappreciated.
How much love they have felt, I guess, this second time around, even though they've been working harder and they're really, really, really tired. So it's tough. And then, I think this month, if I'm not mistaken, October is Respiratory Therapy month. Talk about a cohort of people that probably saved half the lives that we're talking about got saved. I mean, you just can't say enough about the respiratory therapy, an unsung profession in medicine that is absolutely essential during this epidemic.
And I'll just add real quickly, historically, because I've been around longer than any of the others, I think nurses have always had a tough position. Burnout has always been a problem.
Mm-hmm.
They're not been appreciated to the level they should have been, and hospitals have taken advantage of them with requesting double shifts and extra and everything else. So, yes, there is a shortage, but we've not helped things. The hospitals haven't helped things at all. Funding is the biggest thing. We've got to fund more nursing positions, and we've got to get where nurses are appreciated so people want to go into nursing again.
We've talked a lot about, all the signing bonuses that different places have offered, but what retention bonuses have they offered? And that's partly on the hospitals, that's partly on the employing agencies, but a lot of it's on the federal government too. When you hear about, there was an article in the paper, I think last week, about how much FEMA money has gone towards, has been misappropriated into different places, schools rebuilding football stadiums and stuff like that with all this emergency money. But the nurses are making pretty much, maybe a little bit more, but not near as much as they should be given what they have done. I mean, we've talked about it a lot at several different levels. How can some of that money be translated into retention bonuses for those people who have produced? I mean, in the military, we give hazard pay to people who go in the field. It's no different.
I think it's interesting, the timing of the story, because I think the story, we were talking about this fortunately many months ago, about the incredible lift of the respiratory therapists and the frontline workers who were essential and have always been essential through this crisis. But to me, it seems a little bit opportunistic to bring up this story in relation to vaccine mandates when we need to be having a conversation about Southwest Airlines and what's behind that. It's clearly not the weather. I mean, I think they're retreating from some of that, again, spin that somebody thought we couldn't handle the truth that, vaccine mandates are probably going to affect some pilots, and there will be consequences as a society when we make tough decisions, and maybe appropriately so. But the fact that we're not even given the benefit of the doubt to enter into that conversation, much like the nurses, how many in New York did walk away? Well, does anybody trust any of the information that's flowing from there? I mean, I'm going to take it all with a giant grain, a slab of salt, because it's going to be agenda first, information second in how it's packaged.
Yeah, that's right.
But we're at the cusp of seeing what the mandates are doing. And we should be looking at those as kind of the canaries. If the canary's flapping around on the ground and still alive, great. Maybe we keep going. But, I would say Southwest had a dead canary on the ground the last couple of days. And we need to talk about that and make a better strategy. Maybe the mandates are rolled in or, I don't know what it is. But just hiding that information is not good. And I think part of that story in USA Today that you were mentioning is part of spinning. It's not the vaccine mandates. It's this ongoing 20-month story of fatigue. Well, yes, it is. And we should have been talking more about the fatigue and not just waiting for this moment to tee it up as a not vaccine mandates. It's fatigue story. It's been fatigue story ever, particularly since we hit the Delta wave, where it looked like we were going backwards and all the hope sucked out of everybody. Now that's you can ask Texas what that feels like. In the fourth quarter, they lived it, and we're going to live it too. We are living.
Yeah. This employee thing is across the board. I mean, nurses, that's a big deal. But I mean, going to Texas this last weekend, they didn't have enough staff in the hotels. A lot of the hotels are short-staffed, and everywhere you go, you're hiring now. All sorts of jobs are open and not getting filled, and so I think it's across the board. It's a cross-border issue.
We'll throw a mandate on top of that job situation, right?
Yeah.
you know, that it might be the right thing to do, but let's at least say, well, that seems like it's fuel, you know, gas on the fire at this point. If you're talking about finding people to do jobs, you've just driven away X%, right? Not going to do that. Not interested. You know, I'll start my own internet company. I'll do whatever I'm going to do.
Yeah.
All right, well, I know we have got to get going. There's a lot of questions that came up at the end. If the docs have a chance to look those over with, that would be great. Thanks to all the great questions that came in. We're butting up a hard stop tonight at 8:00, and so thank you all. By the way, they'll take a look at those. We've always been a deep dive G-rated program. I'm going to do something really offensive to end the show tonight, but only if you're south of the Red River. Thanks, everyone. I know.
You know why it was so
Sooner.
windy in Oklahoma yesterday?
Now that's 4 fingers down, right? For 4 in a row. Is that right?
All right. Good night, everyone. Have a great week.